I was born 6 weeks early, and I was just 4 pounds. I could not breathe, and I couldn't even eat. I couldn't even eat, and I couldn't even breathe. Anyway, I spent a month in the neonatal intensive care unit, or NICU, and it was because of doctors like Alexa Craig that I'm standing here today. Dr. Craig is a neonatal neurologist and clinical scientist at Maine Medical Center. She is currently researching ways to prevent brain damage in premature babies. She was recognized at the March of Dimes in 2016 for her work. Please note also that after each presentation, we will have a brief question period, so we'll run around with a wireless mic and you guys can ask questions. And please welcome Alexa Craig.
Okay, I was told I had to walk around and not hide behind the podium, so this is me out of my element, but I had to stay with my PowerPoint slides. Thank you so much for that kind introduction. I wanted to talk to you today about what gives me hope, and that's the human brain. The human brain is an absolutely amazing thing, and what I'd like to share with you is the very interesting idea that the human brain is the only organ that actually studies itself. Kind of a weird way to think about things, isn't it? I spend my life using my brain to study other people's brains. Many of you probably are aware of the anatomy of the brain, but I just wanted to walk you through some of the very brief and basic points of the brain. So if I have a pointer, here we go. So this front part up here in green is the frontal lobe of the brain, and that's the part that is in charge of executive function, so helping us, kind of focus, concentrate, remember to think before we act. All very important things to do. This is called the frontal lobe. Over here in yellow, we have the parietal lobe. That's a part of the brain that really helps us integrate the information that we get from our sensory part of our world. And then, and perhaps what some might consider a design flaw, this part back here, this purple part, which is as far away as you can possibly be from the eyes, is where the vision center is, where all of our visual input is processed. And then over here in red is the memory and learning center, which is in the temporal lobe, okay? Down here, what I call the basement of the brain is a really important part called the cerebellum. That controls our balance and coordination and movement. And all of these parts together are comprised of 86 billion neurons. That's a billion with a B. Isn't that absolutely staggering? This actual number was hit upon by a woman who was doing research in Rio de Janeiro. She was an assistant professor. And what she did was she was given or donated 4 brains of middle-aged men between 50 and 71. And she actually had this detergent that she used to break down the cell membranes, and then this incredible counting mechanism to actually count all the nuclei of the cells in those brains, and came up with this number of 86 billion. I can't help but wonder what the number would be. Sorry, guys. Gotta throw a little humor in, right? So the size of the brain is really interesting when you think about it around different species. So here's a human brain. As we know now, it contains 86 billion neurons. An elephant's brain is much bigger. And for those of you who have ever gotten caught in the debate with somebody about whether cats or dogs are smarter, we know that dogs have 500 million, and I'm sorry for the cat lovers out there, they only have 250 million neurons. Mice are the real losers, they only have 75 million. And notice that these are not billions anymore, these are just millions of neurons, okay? We've gone down a whole lot. So what really matters is actually not how many neurons you have, but how many neurons you have compared to the size of your body. And that's where humans are really the winner species, because our brain accounts for 2.1% of our body size altogether. Whereas a dolphin, which actually has a bigger brain by mass than we have, it only accounts for 1.2% of its body weight, if that makes sense. So it's really the proportion that matters. The other thing to know about the brain is it's a total energy hog. It would not be approved of in this current environment where we're trying to reduce and reuse and recycle. So even though it accounts for only 2% of our body's mass, it uses up 20% of our body's energy. Okay? No other organ even comes remotely close to that. So what is that energy? It has to come from oxygen and glucose. Those are the really, really important things that let the brain do all of this miraculous work with those 86 billion neurons. And that energy is brought to the brain through these arteries that go up through our necks by our wonderful hearts that are pumping the blood around through our bodies. Things can interrupt that blood flow. So for adults, you can have a heart attack and suddenly the pumping stops and suddenly your brain is not getting enough oxygen or glucose. The other thing that can happen is you can have a stroke where suddenly a clot forms maybe right here in a blood vessel and the area past that point of a clot can no longer get its oxygen or glucose. Fortunately for me, I don't have to deal with these adult issues. I primarily focus on what happens in babies. And babies, at least term babies, who I'm going to talk about today, have interruptions in their oxygen and glucose supply predominantly around the time of their birth. And these are kind of, I don't know, I hope they're not too gross pictures that show all the different things that can happen around the time of a delivery that could cause a baby's brain to not have enough oxygen. So for instance, in this case here, the umbilical cord was being delivered way ahead of the baby. And what that means is every time the uterus contracts, there's no blood flow getting to the baby from the placenta, and hence no blood and oxygen to the baby's brain. So in my role, and I think I have the best job on the whole universe, I'm a neonatal neurologist and a scientist. I get to combine these things. I'm tasked with the job of helping to protect these brains, these vulnerable brains, so that they can get here safely, okay? So I love these kind of slides. I'm sorry to geek out for a moment, but this is at 25 days of pregnancy, the brain is not even recognizable as a brain, okay? And then as you go to like 100 days, it might be the equivalent of a mouse brain here. And then when we get here at 5 months, maybe like a cat brain, and then at 7 months, like a dog brain, and finally at 9 months, we have like the full deal. Like when a baby is born at term, the brain is mostly fully developed, which is pretty amazing. And my job is to help protect it. So I don't know if this might be like a raise your hand time. Has anybody ever heard of neuroprotection from cold water drownings? Is that something that anybody's heard of before? Right? A couple of hands raised. So what we know to be the case is that, and this is a big deal in Maine where we have freezing cold water for about 11 months of the year, I think. If you go in the water for a few minutes, you have what's called cold shock. So you're instantly freezing and you're screaming for help, and then the cold water starts to sap your energy. So somewhere around 20 minutes, you can't keep yourself afloat anymore and you start to sink. So you get, past 35 minutes that you're into the immersion and hypothermia. So this has happened, for children skating on ponds like in the wintertime. And they can be pulled out after what seems like a really insanely long time and actually be warmed up and have intact thinking and cognitive function and not have brain injury. And so that gave rise to an entire field of medicine that we know of as what I call therapeutic hypothermia. In the adult world, we call it targeted temperature management. So when a baby is thought to possibly have a brain injury from something that happened around the time of delivery, what we do is we put them on this cooling blanket. So it sort of looks like a heating pad, except the heating pad circulates cold water in it, and it keeps the baby at 91 degrees Fahrenheit or 33.5 degrees centigrade. And we do this for 72 hours, and then we warm them up very, very gently over those next 12 hours. The important piece for me is that we have, as a neurologist, right, I have to talk about EEG. These are the leads that we put on the skull to monitor the brainwave activity to make sure there's no seizures. So we do that the whole time, and then we get to get an MRI on day of life 4 to make sure that hopefully an injury didn't happen. So this is what it looks like for a baby who's being treated with the cooling treatment. And we do this between 40 and 50 times a year at Maine Medical Center because there's that many babies born in this state when something goes wrong. And this is it's getting a little dated right now, but my shout out to Anna and Elsa from Frozen. People often ask me, what's the downside of this? Does it harm the baby? Babies tolerate this incredibly well, okay? So we're not causing any harm by doing this to them. So I just wanted to give you an example of a baby who had this treatment at Maine Medical Center. So he was born at 39 weeks. His mother was going through the normal process of labor, and then for reasons that we never knew, his heart rate started to bottom out. So the obstetrician made a decision to do a cesarean section, sort of emergently. And once he was born, he wasn't breathing, and his heart was beating, but not very strongly. So he got the full resuscitation, he got chest compressions in the delivery room, they put a breathing tube in him, put him on life support, and transported him to the NICU. It was a really kind of a hard decision to treat him with hypothermia because he didn't meet the criteria that we use perfectly. But we decided, mostly driven by me, that because his neurologic examination was abnormal, that he would benefit from the treatment. And I'm a little bit embarrassed to say that I was very happy when he had some seizures on his EEG, because that meant I had done the right thing. We gave him a dose of phenobarbital, which is what we use to stop seizures, and he had a normal MRI at the completion of his cooling treatment. And I just want to show you, this is where I have to step over just one moment behind here. I want to show you what he looks like. So I see all of the babies that I take care of.
Okay, Dan, look over this way, Dan.
Okay, I see them all when they're 3 months old, 6 months old, and 12 months old. So here he is at 3 months. Isn't he gorgeous? I love this child. I kind of love all of my patients, but this one's especially cute. So here he is. So, this is what you want your 3-month-old to look like. You want them to be bright-eyed, with good head control like this, moving around. And then this is the real killer one here when he's 12 months old. He's absolutely adorable. He's quite a good walker. This is better walking than most 13 months. Isn't he gorgeous? He kind of likes to ham it up a bit. So the only sad thing about this story is because he's perfectly normal, I don't have to see him anymore. So he doesn't come to my clinic to see me. But I'd like to think that because we made the decision to treat him with therapeutic hypothermia, that that's why he's this normal. So what I want to make sure that you understand is that I didn't invent therapeutic hypothermia. I'm implementing a technology that's well understood and established, basically since the mid-2000s. But what I want to talk about now is the research that is actually mine, that I'm doing here in the state of Maine to make this more accessible to other patients and other families all over the state. Because Dan was really lucky. Dan was born at Maine Med, and I happened to be in the NICU when he was born, and somebody said to me, hey, would you go check him out? And that probably wouldn't have happened if I hadn't been physically there. So in Maine, everybody knows we're a very rural state. We might lose track of that in the southern part of the state, but I go all over to the northern part of the state, and it gets really rural really fast, okay? So if you think about all of the little community hospitals, this treatment can't be done at Inland Hospital or in Belfast because they don't have a NICU, number one, and they don't have a me to read the EEG. So what we have to do is we have to figure out how to get these babies transferred from these community hospitals to the 2 tertiary care centers, either us or Eastern Maine Medical Center, where this treatment is offered. And the reason this is such a big deal is that 3/4 of the babies that we treat at Maine Medical Center are born in community hospitals. They're not born with us. So this transport is a big deal. So the way the situation is right now, if a baby is unexpectedly born who needs this hypothermia treatment, the family medicine doctor or the pediatrician will get on the phone, and it seems like it's a system that's about this antiquated, okay? They call the NICU and they try their best to explain what's going on. There's a time crunch to all of this too. You can't just start hypothermia at any old time. You have to start it before the baby is 6 hours old. So they're on the phone and the neonatologist is checking the clock, trying to calculate whether or not they can get the ambulance there, get the baby back, all before the 6-hour window closes. And there's this ambulance involved, and can they get everybody there? Is it snowing? Are we even doing transport? That was it's never happened in November before, but that just happened a couple weeks ago. So on the phone, that doctor at the outside hospital is trying to describe in words to the to the neonatologist at Maine Med, do we have a normal baby like this guy right here? Do we have a baby who is kind of like just not moving enough? This baby kind of, if I had a video to show you, was just kind of laying there staring. She's what we call stunned, okay? And then there's this baby who's also kind of staring, but he was so sick he has a breathing tube right here. And then this baby here who was very critically ill. So they're trying to tell with words which one of these babies are we looking at. And that gave me the idea for a research project. And I was very lucky to be funded for this project through the Northern New England Clinical and Translational Research Institute, which I don't know if you guys have heard about, but we, together with the University of Vermont, 2 years ago, got a $20 million grant funding pilot studies like mine over a 5-year period. So I didn't get the 20 million, I just got 50,000 of it. So in this research study that I'm currently still enrolling patients for, what I'm trying to do is to show that instead of using this antiquated telephone system, if we use an actual live teleconsult, basically like FaceTime with the outside hospital, that we can recognize babies better, more quickly, and get the hypothermia treatment started sooner, because we actually know that that improves outcomes. The faster it started, the better these babies do. So I am a energetic kind of a person. I feel like you go big or go home, so I just approached all the hospitals that I thought might say yes, and they all did, which was kind of exciting. So we went live with Maine General Augusta first in May, and then we went to Midcoast in June. Penn Bay came online, I think, in July, Mercy Hospital in September, Southern Maine just this week, and then I ran out of money, and I need more money for cameras, so we're trying to work on that. We do these consults. I developed this kind of poster that's on the wall of the newborn nurseries all over the state. And what we've asked doctors to do is call us for babies who they think fall into this yellow range. So no longer do those doctors who don't do this procedure have to figure out, does their baby meet criteria? They just check this poster and then they call us and we do this video consult. So I hope one day, being the ambitious individual that I am, to link up all these hospitals. We would be one hub down here in where Portland is, right around here, and then the other hub would be Bangor, and they would serve all of these northern hospitals. This is what it looks like when we actually do a teleconsult. This is a friend of mine, Stephanie Phelps at Midcoast Hospital, and she brought a Yoda doll in to play with that day. We were having a lot of fun with that. And you can see that it's me and the outside hospital, and then the neonatologist also. So it's a kind of a three-way conversation. We didn't like this setup as much, so we eventually went with a system called video. So this is what it looks like. So this is Gina, different neonatologist, and a very serious-looking group of us. So going back to the original question, like why am I telling you that the brain gives me hope? It's because this therapeutic hypothermia treatment prevents children from being like this patient of mine. So this is one of my children that I take care of in my cerebral palsy clinic, and she has what's called quadriplegic cerebral palsy, so she can't talk and she can't walk, and she actually eats through a tube that's placed in her stomach. We're taking really good care of her. You can see she's super happy and adorable. But this is what happens to these babies, some of them, not all of them, who have oxygen and glucose deprivation to the brain at birth. And wouldn't you rather see a kiddo like this guy, running around your office when he's 12 months old, knowing that this might have been what happened to him without this intervention? Kind of gives me goosebumps. So for the younger people in the audience, I figured I should end with like an unsolicited advice slide. So I think why I've been successful in this project and in my career so far is because I was really lucky and I found my passion and I made it my career. So that's my first bit of advice. And my second bit of advice would be keep learning, keep going to school. I'm 44 years old and I'm about to finish a master's degree, and I needed it because I needed to learn how to do research. And I think that it's a really important thing to just keep getting education because number one, it's fun, and number two, you can do your job better. And then the third thing is live in Maine. If you're really lucky, you get to put it all together in the place that you love as well. And that would be the end of my talk. So now